So here we are going to talk about eating disorder. So according to this PowerPoint, what are the description? Eating disorder are characterized by uncertain self-identifications and grossly disturbed eating habit. So compulsive overeating. Compulsive overeating is being like overeat without purging. What does it mean? So the most common eating disorder in United States marked by episode of eating large amount of food. What are the risk factor of eating disorder? Basically, sex, like female, or age, young adult, mental health disorder. So how you understand a patient or a client as a eating disorder? And what are the nursing care? So the person who have this problem, the sign symptom, eating larger than normal amount of food weekly for more than 3 months. So they finish the food what usually normal person can eat. They can finish within a week or weekly for more than 3 months food. Weight gain or weight fluctuations, concerned about body weight and image, or low self-esteem, feeling of shame after eating or binging, also abdominal cramping or pain is most common. So food consumption is out of individuals' control and occur in a stereotype fashion, repulsed by eating, and that is eating relieve the tension but does not produce the pleasure. Aware that the eating pattern are abnormal and feel depressed after eating. Eat during the meal and consume high calorie and easily digestible food. So what are the treatment and what are the nursing care? Before to go this, I want to explain a little bit more. Eating disorder, they said, dieting is an attempt solution to get in control. Then weight loss, positive reinforcement from others, and more dieting. Developmental pressure like adolescence, sociocultural pressure, biological predisposition, psychological predisposition, family dysfunction. Now go for more weight loss. Who is too much concerned? Feeling power and control, more weight loss. Patient develop another eating problem called anorexia nervosa. Another, on the other hand, always feeling hunger, anger, or being eating, feeling out of control, are going to regain a sense of control, and this is called bulimia nervosa. In this PowerPoint, we will clear it out, the difference between anorexia nervosa and bulimia nervosa. Due to some unknown reason, NCLEX board like to ask question either anorexia nervosa or bulimia nervosa. Eating disorder, compulsive overeating. So repeatedly try to diet, but without success, feeling helpless, feeling hopelessness about the weight control. Also, response to feeling of guilty, anger, depression, or loneliness, inadequacy, right? So this patient thin, but they thought they are getting overweight. So eating disorder may individual, treatment they can try individually correct, or they try group or family talk therapy, CBT, or nutritional counseling can help. Medication for comorbid psychiatric condition like antidepressant medication can work. Mhm. So some doctor prescribe SSRI or CNS stimulant drugs. Mhm. So next go anorexia nervosa. So before to go start anorexia nervosa, I want to share something more. The nursing care plan, nursing care for eating disorder. Like as a nurse, we maintaining strict input-output chart for the patient. We monitor their daily weight gain or loss. So weight patient first thing in the morning using same scale. Stay with patient during the meal and for not more than 1 hour after meal. So always offer prevalence for the treatment, compliance, and weight gain. For inadequate oral intake, tube feeding may be ordered. Restrict the strenuous activities. Monitor for refeeding syndrome, or which can occur after prolonged starvation. So we always encourage the patient to keep a food diary, work with patient to establish a realistic weight loss goal. We provide the reference to support the group. So now let me read about anorexia nervosa. What are the risk factors, signs, symptoms, and inpatient hospitalized criteria we will discuss here. So anorexia nervosa, basically restriction of calorie intake and resulting in dangerously low body weight. So the onset often is associated with stressful life events. Body image is distorted and the client has a disturbed self-concept. Preoccupied with food that prevent the weight gain and has a phobia against the food that produce the weight gain. So anorexia nervosa and bulimia nervosa both are body dysmorphic disorder, but totally opposite. One is thin, right? So body image distorted. Eating disorder can life-threatening. They avoid to eat. And death can occur from starvation, suicide, cardiomyopathy, and electrolyte imbalance. So usually eating disorder, anorexia nervosa, most common female risk factor. Some age like adolescence, early adulthood, or some kind of psychiatric disorder, most common. What are the signs, symptoms? Extreme thinness. You see the picture, extremely thin. It is called emaciation. Patient develop amenorrhea or drown hair or hair growth. It's called down hair growth. Cold intolerance, brittle nail and hair, severe constipation, lethargy, decreased heart rate, decreased respiratory rate, decreased blood pressure. So appetite loss, refusal to eat, appetite deny, feeling of lack of control, compulsive exercising, overachieved, and perfectionist. This is the problem, right? So who go for hospital in anorexia nervosa or inpatient hospitalization criteria, we said? Let me read it. Physical alteration. Many occur and can include decreased temperature, pulse, blood pressure, weight loss, gastrointestinal disturbance such as constipation, denture and gum deterioration, esophageal varices from inducing vomiting. Patient put the finger inside the mouth and they vomit. It is called induced vomiting. Electrolyte imbalance, dry, scaly skin, presence of extremity means extra hair developed, sleep disturbance, hormone deficiency, amenorrhea for at least 3 consecutive menstrual period, cyanosis and numbness of extremity, and bone degeneration. So let me share with you who has to go to hospital. So inpatient hospitalization criteria we call. If electrolyte abnormalities, so if a patient do not eat and their condition look like this, so we have to check the electrolyte. Okay. And heart rate, daytime heart rate, if less than 50 beats per minute, it is the criteria. Send them to hospital. If the systolic blood pressure less than 90 millimeters of mercury, or patient develop arrhythmias, body temperature less than 96 degrees Fahrenheit, or less than 75% body weight, or body fat is less than 10%, or refusal to eat, inadequate response to outpatient therapy. So it is important to send them to the hospital. Second eating disorder here, it is called bulimia nervosa. Basically, here we are going to talk about risk factor, sign symptom, laboratories value, and inpatient hospitalized criteria. So bulimia nervosa here, description said, eating beings followed by purging behavior. So you eat too much. During the eating, you forget everything. But after eat, you feel guilty and you put finger inside the mouth and you vomit. Right? So being eating followed by compensatory measure to avoid the gaining weight. So during the eating, you forget that you going to gain weight. Now you feel depressed and now you're thinking how to reduce your body weight. But when you go again eat, again you forget and lost the control of eating. So patient after eat, patient try to vomit, they eat laxatives or extreme exercise they do. So who is under the risks? Usually female. Hmm? So they said most clients remain within a normal weight range, but feel that their lives are dominated by eating related conflict. So the most common sign, symptom of data collection, say parotid gland swelling. Most of the patient, parotid gland swelling, dental erosion, or we call Russell's sign, means uh, the the weight fluctuating, but most of the patient not underweight. Dehydration, chronic inflamed or sore throat, GI issue is most common. Let me read it. Preoccupied with body shape and weight, consumption of high calorie food, and being Pargo syndrome, attempt to lose weight through the diet, vomiting, enemas, and also they use some kind of antipsychotic medication or diuretics. Has need for control yet experience the feeling of powerlessness or loss of control. Eating disorder, bulimia nervosa, we are talking about right now. What else? Low self-esteem, poor interpersonal relationship, decrease or absent in interest in sexual activities, mood switching, electrolyte imbalance, physical alteration, similar to those that occur with anorexia nervosa. So if you go for laboratory test or lab test, we can see hypokalemia, hyponatremia, metabolic alkalosis. This is the question NCLEX board asks. In case of bulimia nervosa, we can see metabolic alkalosis. So who supposed to go to the hospital? Bulimia patient, I said. If patient has syncope or hypothermia, potassium level less than 2 milliequivalent per liter, calories less than 88 milliequivalent per liter, or esophageal tear, they put finger inside the mouth, arrhythmia, or intractable vomiting. Hematemesis means blood mixed with vomiters. If the patient has a suicidal risk, ideation, or inadequate response to outpatient therapy, it is good inpatient hospitalization. Next, eating disorder continuation. What are the intervention or nursing care? I already explained a little bit, but I want to recap it again one more time. Assess the nutritional status and severity of any medical problem. Established a one-to-one therapeutic relationship with client. The nurse needs to establish trust and recognize any client reluctance to establish a relationship. Establish a plan concern the nutritional plan for day. Assist the client to identify precipitant to the eating disorder. Encourage the client to express the feeling about the eating behavior and about how he or she feel about his or her body image. Be accepting and non-judgmental. Work on exploring the self-concept and establish identity. Implement behavior modification techniques. What next? If in a healthy care facility, supervise during meal times and for a specified period after meal, and monitor intake and output, set a time limit for each meal, and provide a pleasant, relaxed environment for eating. Monitor for sign of physical complication related to the eating disorder. Weight the daily at the same time using same scale after client weight, right? When weighting the client, ensure that the client is wearing the same clothing as when previous weight was taken. Monitor and restore the fluid and electrolyte balance. What else? We have to monitor elimination pattern, assess and limit the client activity, encourage the client to participate in diversional activity, assess the suicidal potential, administer antidepressant medication, encourage psychotherapy, and refer the client for support therapy, right? So in a short, what are the treatment? Treatment is CBT or DBT. DBT means cognitive behavioral therapy, okay? Or medication like SSRI, central nervous system stimulant can work, or some kind of surgical operation like bariatric surgery. So as a healthcare provider or as a nurse, we encourage the patient to keep a food diary, work with patient to establish the realistic weight loss goal, provide referral to the supportive group. Means if they work in a group, it should be more productive. So when we work in the hospital with any patient like this, we maintain strictly input-output chart or offer prevalence for the treatment compliance. For inadequate oral intake, we better to use tube feeding, may be ordered. Monitor the refeeding syndrome. Okay.